Well, I'll get started. Hello everyone. My name is Clinton Olivas. I'm one of the inpatient chief residents at the Seattle VA. And it's my great honor to announce the winner of this year's Beeson Award. To remind everybody of this award, Dr. Paul B. Beeson was a distinguished professor of medicine, spending his final years of practice at the Seattle VA Medical Center from 1974 to 1981. He was a legend not just in our program, but in the field of internal medicine, where he was best known for his extraordinary teaching skills and beloved for his incredible spirit. To quote Dr. Petersdorf, who was UW Chair of Medicine during those years, he said, Paul Beeson has taught us, probably more than anyone else in academic medicine, how to live the academic adventure fully, how to live it with humility and humor, with style and graciousness, and to live it with an understanding and kindness for his patients, his students, and his colleagues, in a spirit of giving to all of them more than he has received. In short, he has been the example of what the best in academic medicine is all about. And so, in order to honor Dr. Beeson's legacy, each year an award is voted on by the GITCU resident house staff and is granted in his name to recognize outstanding clinical teaching by a faculty member who exemplifies scholarship, humility, compassion, and integrity. The winner is chosen solely by the internal medicine house staff. This year, outstanding faculty members were nominated, with one clear winner emerging who certainly embodies all the qualities of Dr. Beeson's legacy. And please join me in congratulating the winner of this year's 2026 Beeson Award, Dr. Nina Tan. I've had the pleasure of working with Nina at the Roosevelt Clinic before, and so I wanted to kind of tell you all a little bit more about her. Dr. Tan is an acting instructor at the University of Washington as part of the General Internal Medicine Division. She earned her MD at the University of Washington, where she stayed to complete her residency in internal medicine. She is currently at Roosevelt with the OB-GYN and primary care clinic, where she teaches both internal medicine and OB-GYN residents. She also serves as the director for the Internal Medicine Women's Health Pathway. Dr. Tan also works part-time at the Fred Hutch Breast Health Clinic, where she cares for patients who are at high risk of breast cancer or are post-breast cancer treatment. And she has many scholarly achievements that exemplify her passion for teaching. But some scholarly achievements that I included here were hosting regional workshops on abortion and menopause care, and then acting as a co-chair of the Washington chapter ACP conference in 2025. Congratulations to Dr. Tan. I'm not sure if we're able to give her permission to speak briefly on this talk, but if she's present, would love to hand it over to her.
I'm going to go ahead and introduce Austin while he pulls up his slides. I think most of you here know Austin pretty well. He's currently one of the inpatient chiefs in internal medicine here at the University of Washington, Montlake. Austin grew up in Kirkland, Washington, but then spent the subsequent 10 years on the East Coast, where he studied biomedical engineering at Harvard, followed by medical school at Columbia, New York City. After medical school, he then spent an extra year doing research for his master's in biomedical sciences. In July, he's going to be starting pulmonary and critical care fellowship here at the University of Washington. Austin told me in quotes that he's very excited to present at Grand Rounds today, but he feels this may be his first and only time giving Grand Rounds during his career, and I beg to differ. He is in the research track, and I think things will go very smoothly for him during his career. I think Austin will probably be asked to give talks all over the country. Austin is truly an incredible doctor, resident, chief resident. He is thoughtful, intelligent, one of the best residents I've worked with, and definitely the best co-resident I could have ever asked to work with. He's exceptional, hardworking, and I feel so lucky to work with you. So please welcome Austin. And for those of you online, just put your questions in the chat and we'll address them at the end. Thanks.
Um, Thank you, Hannah. That was a very nice introduction. Um, yeah, I really appreciate that. Hannah is also an incredible chief. Very much enjoy working with her. Um, my name is Austin. I'm one of the intermedicine chief residents, as you've heard. I think it does feel a little bit early in my career to be giving a grand rounds talk. But I am excited to talk about bronchiolitis obliterans syndrome. That's some of the research I've been doing the last couple years with Dr. Guangxing Chen. She's actually in Croatia right now giving a talk on BOS, so she can't be here. But she did look over these slides. So the title of my talk is not just popcorn lung bronchiolitis obliterans syndrome after hematopoietic stem cell transplant. The alternate title is Who's the Boss? So John Cho is in the back here and gave that suggestion. He said folks in the room would understand this reference. I haven't seen this show, but the acronym for BOS is, or bronchiolitis obliterans syndrome is BOS. So this talk is also titled, Who's the Boss? Disclosures. I have one disclosure. I don't actually know if I need to disclose this, but I'm a campus representative for AMBOSS. I get no financial benefits from this position. Outline, we'll talk about popcorn lung and the causes of bronchiolitis obliterans. We'll talk about bronchiolitis obliterans syndrome and how that's a little bit separate from bronchiolitis obliterans. And then we'll take a deeper dive into BOS, specifically after stem cell transplant, talking about the diagnosis, the heterogeneity of the disease and its course, and the treatments. We'll talk about the introduction to my research with Dr. Chang, and then a little bit of next steps for diagnosing BOS and its treatments. For some vocabulary, when I say GVHD, usually I'm referring to chronic GVHD, and GVHD is graft versus host disease. And so that's after a stem cell transplant, when the cells that you've just received are identifying your body as foreign and attacking things in your body. There's also acute GVHD, but for BOS, we're mostly referring to chronic GVHD. Bronchiolitis obliterans, BO, refers to the histologic finding, and then adding the syndrome to it refers to kind of the clinical manifestations of BO, which is that histologic component. Okay, so bronchiolitis obliterans and popcorn lung. So when I first heard about this, I thought it meant that you had popcorn-looking imaging findings in your lungs. And that's how I really remembered it until I started doing research with Dr. Chang. And so what it actually refers to, it's not that you have popcorn lesions in imaging findings. It's more related to how the disease, not how it's discovered, but what it's linked with most. So in popcorn processing factories, there's a chemical component, diacetyl, that's used in butter flavoring and popcorn flavoring. And so there was an investigation into some of these popcorn processing plants and found that a number of workers were developing cough, respiratory symptoms, and diagnosed with obstructive disease by their doctors. And so that kind of then became known as popcorn lung if you were working in these factories and developing bronchiolitis obliterans. And so these patients were then biopsied and on histology had this finding of bronchiolitis obliterans, which we'll talk more about. But it's actually pretty common. So diacetyl and other chemicals like 2,3-pentanedione, those are the ones that were implicated, I think, in the popcorn processing plants, but it's also involved in other baked goods and coffee flavorings and candy as well. And then there's some recent reports that even roasting coffee can release diacetyl, which I didn't look that much into. But the question is, what does it mean for your lungs to and what does it mean for your bronchioles to be obliterated? What is bronchiolitis obliterans? And so it's also known as obliterative bronchiolitis or constrictive bronchiolitis. And what we're looking at is in your respiratory tract. You have your trachea, which branches into your main bronchi, and then your segmental bronchi. And then as they get smaller, they get deemed bronchioles. As they get smaller and smaller, then it becomes terminal bronchioles and respiratory bronchioles. And so at the end here of your respiratory bronchioles is where the alveoli come off of. So really, when we're talking about bronchiolitis and the bronchioles, it's referring to these small airways after your lungs have really branched a lot and right before the alveoli. And then the obliterans portion is kind of indicating this is on histology. So in this top left corner, this is a normal bronchiole, and you can see that this airway is still open. You can have gas exchange as it passes over to the alveoli. But then here, this is a patient 8 months after a stem cell transplant, and they developed bronchiolitis obliterans syndrome. And then on histology, they have this kind of obliterated lumen here. And so what's happening is that with chronic inflammation, the bronchial walls start to fibrose over time, and that lumen gets smaller and smaller, and you kind of lose those small airways. And so that's what bronchiolitis obliterans is referring to, that histology, and then the syndrome is how you feel after. And so then it is a question, do you have to biopsy everybody, or can you diagnose it in another way without having to biopsy? And so for the most part, we try not to do the biopsy, and we look to see what clinical symptoms they'll manifest. So often with small airways disease, you can manifest as airflow obstruction. And so in this case, we learned that in COPD, it's irreversible airflow obstruction, and asthma, you can reverse it with bronchodilators. Bronchiolitis obliterans is a fixed airflow obstruction, so it's not reversible with your inhalers and your things like albuterol. And so what we can do is we look at lung function with pulmonary function tests or PFTs, and we can look at this ratio, FEV1 or FVC, and kind of previously, it's less than 0.7 is the ratio that you'd term as obstructive disease. And for BOS diagnosis, we'll talk about that 0.7 is still used, but for other things now, it's kind of dependent on your age, your height, and what percentile you are for you to have like an abnormal airflow. So we can look at those PFTs, and we can also look at imaging. And so here is a CT scan of the chest. We have an inspiratory image up top where someone's taking a deep breath, and you can see some dilated airways or tree and bud appearance. And that tree and bud is just showing that those small airways are obstructed. And it's non-specific and doesn't tell if it's BOS or not, but that the small airways are involved. And then with an expiratory film, someone's tried to blow out all of their air. That can indicate a few different things, but in this situation, we're looking for air trapping. And so air in the lungs looks black, and then more consolidated tissue is whiter. And so in this area, you have different areas that are black and white, which we call mosaic attenuation. And that means here the air is trapped and you couldn't get it all the way out. And so there's some residual air and maybe another indication that you have obstructive disease. Okay. So then now talking about what causes obliteration of the bronchioles. So we talked about occupational issues, and so diacetyl is involved. There's a number of other chemicals as well. So sulfur mustard was used a lot in the Iran-Iraq war, and a number of soldiers afterwards developed obstructive diseases, and on biopsies that are found to have bronchiolitis obliterans. And then also things like fiberglass and incinerator fumes. We're going to focus also mostly on post-transplant. And so that's either after lung transplant and also after stem cell transplant. The title of the talk is BOS after stem cell transplant. So we're mostly focused on after the stem cell transplant, but we'll talk a little bit about the lung transplant. And then you can also just get it from general inflammation in that area chronically over time. So it's associated with rheumatoid arthritis as well. Initially thought to be medication related, but actually it seems like rheumatoid arthritis can also just manifest in the lungs as bronchiolitis obliterans. And then after viral infections, usually more in children, and common viruses that were indicated are adenovirus, measles, and mycoplasma. And usually it's self-limited, but sometimes it can the dysfunction can last. Chronic reflux and microaspiration over time can also lead to bronchiolitis obliterans, and then severe chronic exposure to air pollutants too. Okay, so this is just a reminder, bronchiolitis obliterans is obliterative bronchiolitis. And it's also constrictive bronchiolitis. Bronchiolitis obliterans syndrome, BOS, is bronchiolitis obliterans. In this case, we often refer to after a transplant, but mostly because we're not biopsying to look at that histology. And then there used to be bronchiolitis obliterans with organizing pneumonia, but now that's called cryptogenic organizing pneumonia, and that's a restrictive disease that's part of ILD, or the new name is like DPLD, and it's not bronchiolitis obliterans. I see a thumbs up from Ken, so we're on the right track. Great. Okay, and so how do we treat this? For the occupational ones, there are some exposure-specific treatments, but they're not that effective. So what you really want to do is try to avoid the exposure and prevent it from developing. For the inflammatory causes, you treat the underlying cause and then also try to avoid the exposures. And then for the post-transplant, we'll talk more about it. So getting into the post-transplant, so again, this can occur after a lung transplant, so solid organ transplant, or it can also occur after a stem cell transplant. In the case of a lung transplant, this is a form of rejection, and so it's we call lung transplant rejection often chronic lung allograft dysfunction on the acute side, and you can have an obstructive component or a restrictive component, and when it's obstructive, it's thought to be bronchiolitis obliterans. On the stem cell side, this is, again, the cells that you just received from someone else now attacking your own lungs or other organs as well. And it can affect the skin, the eyes, liver, GI tract. And so some people think it's, there's talk that it's two sides of the same coin, just different forms of rejection, and maybe they're similarly mediated. And for lung transplant, 50% are affected within 5 years. For stem cell transplant, it's about 3 to 10%. But those who have developed other manifestations of chronic graft-versus-host disease, about 14% will also develop lung involvement. And then this is just when the definitions and criteria were described. But for lung transplant, it was described first in 1993. At least there were criteria that were set, and then it got revised 2 more times. And then for BOS and stem cell transplant, the first definition was 2005, and then revised in 2014. And now there's discussion of maybe it should be revised again. And we'll talk about why that's the case. So if we compare lung transplant, CLAD, and the definition, it's if your FEV1, the forced expiratory volume in 1 second, so how much you can expire in a second, has declined by 20% or more over a few weeks. But if we look at for BOS after transplant, it's this fixed FEV1 threshold that you're trying to cross. So there is also this kind of 10% decline from your baseline as well, but you have to cross this 75% FEV1 threshold to then get the diagnosis of BOS. So one is relative and one is fixed. And then when we look at the lung transplant, previously it was only described as an obstructive disease, but then there was restrictive components that developed, and they ended up having a discussion in 2019 to say actually CLAD involves both. Whereas right now, after stem cell transplant, the criteria is for your FEV1 over FVC to be less than 0.7. So it only involves, or only includes, the obstructive component. And so, it's a question of, does chronic graft-versus-host disease affecting the lungs, does it only manifest as an obstructive condition? And the answer is, likely no. There's a lot of other lung involvement that can develop, and you can develop like organized pneumonias and ILDs, and you can also involve the chest wall, and you can have truncal sclerosis that also manifests as restrictive disease. And so that can make it difficult to then diagnose BOS because your lung function testing can be difficult to interpret if other aspects of the lung or your chest are involved. But right now, BOS is the only lung condition considered to be chronic graft-versus-host disease in the current guidelines. And then this is just a little bit more elaboration on how to diagnose BOS. So this is the 2014 NIH guidelines. And so the first two steps are to show that there's airflow obstruction. The third is make sure it's not being caused by an infection. And the fourth is if you don't have other causes of other involvement of your organs from graft versus host disease, if this is your first manifestation, then you also have to look for other signs like air trapping on your PFTs, or you look at imaging and look for other signs of obstructive disease. Okay. And then right now there are criteria for screening. And so so you want to get your PFTs at baseline before your transplant, and then you get it after your transplant. And then every 3 months or so, you'll want to get screened. And so for standard risk, it's every 3 months for 6 months, and then you can wait until a year, and then it's a year after that. But if you're a high-risk patient, then you should get screened every 3 months and continue to get screened to see if your lung function starts to decline. And then it kind of raises the question of who is high risk, and so that kind of involves these people are people with prior acute GVHD, people who currently have chronic GVHD, who had peripheral blood stem cell grafts, who had myeloablative conditioning, and otherwise had early post-transplant respiratory viral infections. So all these things are thought to be related to development of BOS, and so you're just trying to screen them earlier so you can catch them before they develop symptoms. And then the other question is the every 3 months adequate? Do people decline within those 3 months of time, and then is it too late to intervene at that point? So that's something we'll talk about. And then there's also access questions and who's monitoring these PFTs. And so just for the general screening guidelines, it seems like actually less than 50% of transplant centers follow these screening recommendations. And so often folks feel pretty well and don't want to get their PFT until they start developing symptoms, where often we know that their lung function has already declined significantly before they develop their symptoms. Okay, and so then the question is, why do we want to diagnose it earlier? So BOS develops in stages where it's inflammation at the start, and as that continues, you start to have fibrosis. And so you want to diagnose it prior to these bronchioles fibrosing, in which case it becomes irreversible. The immunology of it is also still being worked out, but there's suspected to be T cell and like B cell involvement, and that's a lot of the current treatments, which is immunosuppression. Okay. This is just generally talking about then the NCCN guidelines. These guidelines are essentially how to treat chronic graft versus host disease, and it doesn't specifically indicate the lung except for one portion of it here. But different organs respond differently to different GVHD treatments, and the lungs in particular are hard to treat. And so generally, the recommendation is to give steroids, 0.5 to 1 mg per kg per day. And then you can add things here for the lungs, such as inhaled steroids. You can give azithromycin and montelukast. And that regimen combined is called FAM treatment, as fluticasone is often one of the inhaled corticosteroids that gets used, but you can also use budesonide. And they say, if you improve, you can taper your steroids. If you don't improve, now you're a steroid refractory disease, and you'll have to consider other things. And so for the steroid refractory diseases, there's a number of things, but this is referring to pretty much all types of GVHD, not just lung. For us, we're going to focus more on ruxolitinib and belimosidil. And those two drugs, ruxolitinib is a JAK inhibitor, and belimosidil is a ROCK inhibitor. We're not going to talk too much about it, but what they do is they stop pro-inflammatory signals and try to immunosuppress you in a different way than the steroids. And then belimosidil also has some anti-fibrotic properties. But these two drugs are being studied and have some evidence to show that maybe they're helpful for the lungs as well, in particular. And then just putting an arrow down here. So in the guidelines too, this is talking about, most of the treatments are relatively benign, at least not the systemic immunosuppression, but like the airway treatments. But azithromycin, which is something that's otherwise relatively benign, we use it in COPD. It also works pretty well in lung transplant rejection. but in a study called the Allo-Zithro trial, when it was given prophylactically to post-stem cell transplant patients, it's found that they had higher rates of relapse of their hematologic malignancy. And then also there's higher rates of cancers like squamous cell carcinoma of the skin. And so now there are some guidelines or just thoughts of being more careful with using the Zithro, especially if you are within a year of your transplant, if it was for something like AML or ALL, and then monitoring to see if there are like skin manifestations and other cancer screening. So just kind of to emphasize that even though it's similar to lung transplant, it's not something we can entirely just copy the treatments, as there are manifestations that are different than what was expected. And then here, if you've tried all these different steroid refractory things and your patient's still not doing well, you can consider lung transplant as well. And so that's also, if your GVHD is really affecting your lungs and not your other organs, then that could be a consideration, and you have to be a ways out from your initial transplant so that you're hopefully out of the window for relapsing or less risk of relapse. But it seems like for these patients with the limited data available, after a transplant, your comorbidities and issues afterwards are similar to other patients who've gotten lung transplant. Okay. And then this is talking about kind of more BOS-specific guidelines and the evidence that we have for BOS-specific treatments. So this is the European Society for Blood and Marrow Transplantation and the European Respiratory Society. And so this table really is showing, certainty of evidence is all low to very low. And then the recommendation for using is, pretty conditional. This one says conditional for either or. Which is really saying like you could add it to your current standard of immunosuppression, or you could not. We're not really making like a strong recommendation. And I'm highlighting these in bold because these are the ones that we'll focus more on, and that's what we're focusing on in our research. I think what's difficult is just that the evidence is pretty low because a lot of studies, there's not that many RCTs, and the ones that there are, there's low patients that were involved in the study. And then there's some observational trials as well, but a lot of the results will kind of conflict with each other. So an example is for azithromycin, one RCT showed no statistically significant changes in lung function, but another case series showed a 21% increase in FEV1 and a 22% increase in FVC, which it could be pretty significant. And so it's hard to tell what's best. But their guidelines are pretty detailed. So if you're thinking about this, you could definitely go in and look at that. And then some kind of future steps too. So looking at belimosidil, there's the BBOP trial going on that Fred Hutch is participating in. And this is using belimosidil and seeing if belimosidil with standard of care versus belimosidil only, and seeing if there's improvement in FE1 and lung function. And then there's also the use of pirfenidone, and that's being studied now, which is an antifibrotic. So we talked about trying to prevent the irreversible stage of fibrosis, but now thinking about antifibrotic use. And that was done at Stanford, and that was a phase 1 trial in 2022. And that seemed, promising. That did seem to have improvement in FEV1 for these patients that were enrolled. And then there's also combination studies of antifibrotics with some of these newer GVHD treatments. I should have mentioned too, I'm not sure if I said this, but belimosidil and ruxolitinib were both approved for chronic GVHD treatment in general in 2021. And so it's a few years ago where these are kind of the newer agents being used for GVHD. Okay, and then also why it's important. Late lung disease is still a major cause of death in stem cell transplant survivors. And so this green line here, that's right after, all causes is the black line, and then relapse is this orange-red line, and then the line after that is pulmonary causes of death after stem cell transplant. So it's pretty significant. And then here, respiratory failure was about 9.6% of this group that was 937 patients that were assessed for non-relapse mortality. And so it's also significant there. And then these are quotes from Dr. Chang's patients. So, the one that stood out to me is, if I had known I would get lung disease like this, I would rather have died of my AML. And so that's can be pretty devastating for someone who's already been through a lot. So now kind of talking about our research. So I joined Dr. Chang's lab in 2023. And at the time, the goals we had for the project was to try to understand the trajectory of lung function in BOS patients in today's era of chronic graft-versus-host disease and BOS treatments. And so that's talking about the belumosudil and the ruxolitinib. Understanding the previously observed heterogeneity of FEV1 trajectories, and try to learn about the various phenotypes of BOS as well. And then exploring the effect of systemic immunosuppression, generally prednisone or methylpred, and these newer medications on FEV1 trajectory. And so this is Dr. Chang, and she has a joint appointment at Fred Hutch and UW. And then kind of on a personal side note, I grew up around Washington and always wanted to work at Fred Hutch. So I thought this was a really cool way to combine interests in poem and also be able to work at Fred Hutch. So this is showing just the heterogeneity in the trajectory of lung function in these patients. And so in this top panel here, you see, so the x-axis is in days, and this middle here is at BOS diagnosis. So this is prior to the diagnosis of BOS, this is after the diagnosis of BOS, and this is their FEV1. And so we see before BOS, their FEV1 starts to decline, and then after diagnosis, it starts to improve for this patient. And this other patient, they started quite high. This is above 100% for their percent predicted FEV1, and it declines at BOS diagnosis. It then continues to decline. This patient precipitously declines and then plateaus, and then this patient gradually declines and then plateaus. So they're kind of having these different trajectories. This is another study done in Hong Kong, and they also reported on this gradual versus rapid decline. And this is in the first 3 months after BOS diagnosis. They noted that patients had this large decrease in FEV1 by their 3rd month, and then a little bit further up before they plateaued. And then another subset of the folks that they studied declined a little bit slower in that first 3 to 6 months and then plateaued. So this question of, who are these patients that are declining so rapidly? Is it the treatments that were helping those who are gradually declining, or is it something else? Are they kind of refractory to the treatments that we have? So variable lung function trajectories and the gradual versus rapid declines. This is a study that Dr. Chang did in 2016. And so this is a cohort of patients who were part of the FAM trial, so that fluticasone, azithromycin, montelukast regimen, and also a retrospective cohort from Fred Hutch. And then everyone's plotted in this spaghetti plot. And this is showing that there might be this window of opportunity before someone is diagnosed with BOS, that maybe you could catch them before their lung function declines and then plateaus. And so for this cohort, they started out well, declined, and then here, the large majority ended up just plateauing afterwards instead of kind of declining or continue. Or maybe there's a combination of a third, which leads to then a line that looks like it plateaus. And so for our study, there's a currently ongoing prospective observational study called the RV-BOS study. And so that's the line name. The RV-BOS study is longitudinal impact of respiratory virus infection on BOS after a stem cell transplant. Essentially, this longitudinal study where patients are doing home spirometry once a week, and then every 3 months getting their lab PFTs evaluated. And then every 2 weeks, they do a nasal swab for viruses, because it's trying to look to see if viruses are also affecting the development of BOS. And that was a lot of the work was done by Mike Vo, who's one of the internal medicine chief residents at Boise. And he just matched home crit as well, and he's going to be in Minnesota. and he's a great pickleball player if you ever see him. And then this other, so I probably should have started right to left, but the other cohort that we're using is this also completed now prospective observational study. And that was trying to do home spirometry once a week and see if that was something effective for monitoring FEV1 decline and see if you could diagnose BOS earlier. And that was done by Madeline Peja, who's a Pulm Fellow in PEDS here at UW. And so for our study, we took these two cohorts and then tried to find the patients who had 12-month PFTs, so 12 months after their BOS diagnosis, what their PFT looked like. And then because it's every 3 months, there are also patients who had PFTs at 3 and 6 months afterwards. And for those that didn't, we excluded them as well. So our final cohort had 4 time points at BOS diagnosis, 3, 6, and 12 months afterwards. And that left us with about 66 patients. So we also plotted it into a spaghetti plot to see what it looked like. And it just looks like a lot of lines. And so then we did this clustering method called dynamic time warping to try to parse out and see if there were different groups that we could identify within these trajectories. And so it was able to, you can actually kind of set the number of clusters you want. And we ended up going with 3 as that seemed to parse the patients a little bit better. And so when we split them up in this way, you have kind of this group that seems to start off pretty well and they continue to do well. And then a group that somewhere in the middle here and then continues to do well. And then this group are patients that ultimately ended up not doing as well, but you have these patients where we were talking earlier where they decline and then plateau out. Within these, you kind of have some of these lines where there's like a decline at 3 months and then improvement and then maybe a plateau or a slight decline. But when we then mapped out their trajectories in this way, in this box plot format, we also then took a look to see if we were still missing their FEV1 decline before BOS diagnosis. And so here's that first cluster 1, those folks that were doing quite well. Cluster 2 is these folks that were somewhere in the middle, and then cluster 3 is that group that did less well. And we see that for all of them. So this middle is when they had BOS diagnosed, and FEV1 is on the y-axis, and then there's not really an x-axis for the box plots. But here, this is PFT at pre-transplant. And then this is 12 months before BOS diagnosis, 6 months before, and 3 months before. And we see that that is declining by the time they're diagnosed with BOS, even in this group that did quite well. And here again is pre-transplant, 12 months before, 6 months before, and then 3 months before, and they also are declining. But it's like a much bigger, a steeper slope to decline. And then here, it doesn't look as neat of a trajectory here, but we do see some decline and then more of a precipitous drop before BOS is diagnosed. And for these guys, 3, 6, and 12 months after diagnosis, it looks like they're somewhat plateaued already by that point. But here in that third cluster, it looks like they're still declining a little bit more, and then in that first 3 and 6 months, and then they plateau. This line here, the 75%, is that cutoff that we talked about. So you need a FEV1 of 75% or less to diagnose BOS based on the NIH criteria. And we see that actually, this cluster 1 group hasn't met that criteria. So in these studies were also patients that, had either atypical spirometry or maybe suspected to have BOS or had, initial decline already, but didn't meet the criteria yet. And so it's interesting because these folks were included and they didn't quite meet the BOS criteria and they did relatively well and stayed above that line. Some of them still may have received some treatment already, and well, actually they did, and so I'll show that data too. And so seeing if earlier treatment of BOS is helpful. And then these other 2 cohorts, they did have BOS diagnoses officially by NIH criteria. Here we have the FEV1 over FVC trajectory, which is mostly just to also define obstructive disease. And we see that in clusters 2 and 3 that also has that decline and plateau similar to the FEV1 trajectories. Okay, this is looking at residual volume and residual volume over total lung capacity. And so we talked about how other signs of obstructive disease, like air trapping, can indicate that you have BOS. And so the residual volume is also one of the criteria, kind of in that extra criteria. And we see that if that's rising, that tells us there's more air trapping. And this ratio of residual volume to total lung capacity also tells us if there's some air trapping going on. So we see in these groups as well that there's a rise in that residual volume here, and then this is the ratio RV over TLC, and that's also rising. And so we were seeing more development of obstructive disease in these clusters as well after at BOS diagnosis and after. Here's a little bit of just trying to then determine who is that cluster 3, or just really cluster 1, 2, and 3. Who are they, and can we differentiate them from each other? And so cluster 3 is that group that did had a bigger decline and more rapidly. And so these patients were diagnosed with BOS younger than cluster 2 and 1. They developed BOS faster, both faster after their stem cell transplant and faster after they developed chronic graft-versus-host disease. They also had more myeloablative conditioning and more total body irradiation. And then what's interesting is that for this cohort, more of them got cyclophosphamide as well as a post-transplant GVHD prophylaxis regimen. And that there's some thought is that should actually be more protective towards development of BOS. Here for the myeloablative conditioning, that was, one of the high risk factors that we talked about for who should be screened more frequently. And then similarly with having chronic graft-versus-host disease, not like lung manifestation, that's also like a risk factor. And it's known that typically worse BOS develops faster compared to the folks who do better. And then this is showing the treatments between the clusters. So GVHD treatment in general versus BOS treatment. And they're largely pretty similar. So just looking at the BOS treatment, we split it into airway therapies, and that includes the inhalers and also includes FAM therapy, fluticasone, azithromycin, montelukast. And then that airway therapy with prednisone, the airway therapy with some of these novel GVHD treatments, and then the airway therapy with prednisone and some of these novel treatments. And so generally, it's actually all pretty similar. 70% or so of folks got airway therapies only. About 20% of these folks, 15 to 20%, had prednisone added. Here we had a combo of here this is just the novel treatment alone without prednisone, and then this is generally patients who got both the prednisone and the novel treatment. So just trying to say that the treatments in each cluster were generally pretty similar. And so then showing the trajectories clustered or kind of grouped by treatment and seeing if then that did make a difference for these clusters. So we're comparing the airway and FAM groups to patients who received systemic immunosuppression, and now that's prednisone with the belumostal and ruxolitinib, whatever combination of those combined. And so again, cluster 1, cluster 2, and cluster 3. And we're splitting it between airway and immunosuppressive therapies. So this is at the time of BOS diagnosis, and then we have at 12 months after BOS diagnosis, and y-axis is their percent predicted FEV1 again. And so we see that in airway therapy group for cluster 1, it seems relatively stable, but for the immunosuppression group, it seems like maybe there was some improvements at 12 months. When we look at cluster 2, whether it's airway therapy or immunosuppressive therapy, generally they remained pretty stable. And then in cluster 3, airway therapy versus immunosuppressive therapy, also both groups declined. So we still have to talk with our statisticians to see if this is actually significantly, statistically significant. But there's some thought that perhaps if you do catch folks earlier, cluster 1 was this group that didn't meet the NIH BOS criteria. Would systemic immunosuppression actually make a difference? Because BOS was getting diagnosed earlier in clusters 2 and 3 compared to cluster 1, it seemed unlikely that cluster 1 would then develop into 2 or 3? Like if you didn't treat it, would it become 2 or 3? But that raises this phenotyping question of who is cluster 1, 2, and 3, as why do some people decline so quickly, and why do some people do a little bit better, and then perhaps respond well to immunosuppression if you give it early. So that brings us to our lingering questions, take-home messages, and next steps. And this question, right, of trying to recognize BOS earlier. And if we do that, it likely would be able to help with pulmonary morbidity. And it raises this question of whether or not we should be doing PFTs earlier. Right now, it's about every 3 months, but we saw that folks decline within those 3 months of time. And so maybe we need to screen them more frequently. Similarly, there's discussion of revising those 2014 NIH criteria rather than this absolute threshold of FEV1 of 75%. Maybe we should also consider a relative decline as well. And we should consider restricted diseases and trying to figure out how to incorporate those into the diagnosis and splitting those apart from the obstructive conditions. There's also needing to better understand the trajectories and who these patients are, what these phenotypes are. And so one of Dr. Chang's next projects is to develop biomarkers for these patients in these clusters. With those 2 studies, she's collected a lot of samples over the last few years. And so we'll be able to analyze them and see if there's anything that stands out and differentiates each cluster from each other. And then the treatment. And so we showed that the evidence for the treatments right now, a relatively low quality of evidence. And so definitely needing to have larger studies, more RCTs, trying to determine what the efficacy is and what the safety profile of these treatments are. Seeing if upfront combination therapies could be effective, and then trying to identify these patients that could benefit from more initial aggressive treatment. Okay, so that's everything. Thank you to all of these people, Dr. Chang's team, all the folks who are kind of collecting samples and running things. And these studies are all multi-site. And so there's collaborators from Stanford, University of Michigan, from MD Anderson, and then the biostatisticians at Fred Hutch, kind of everybody that's been working on these projects, all my family's friends and mentors who helped me get to this point. And then thanks to all the patients and their families for helping with all this work. Okay, so. Any questions? Yeah. Yeah, okay, so the question was, do we know if how infections play a role into yeah, it's a great question. I was actually talking to Dr. Bendit about this, where I haven't actually taken care of a patient with BOS yet. I've gone to clinic with Dr. Chang to try to see them. But my understanding is that it often is for those patients in like cluster 3 where they just decline precipitously. Sometimes you can just continue to decline, and then it is respiratory failure from your BOS that's not responding to treatments, in which case then you're considering possibly lung transplant if it's available. But then also these patients are often quite immunosuppressed and do have complications of infections. And it's one of the thoughts with the RV BOS study is trying to see how much these infections are contributing to the BOS development, and also then if patients are recovering after their infections. Often it becomes sometimes this like stepwise trajectory where each infection, their lung function declines, and then some will recover and some don't, and you can kind of continue to decline in that way. Yeah. Yeah.
all the data is great, but
Yeah, that's a great question. Yeah, no, so that's a great question. So the question was, um, I cited that less than 50% of transplant centers are able to do the screening every 3 months for with PFTs for these patients that are post-transplant, and why. And I even trying to do this project in patients enrolled in these studies where you're required to do your home spirometry and also come in for these clinic PFTs, there's a lot of missing data. And so I think what can be difficult, especially for this, is when patients are feeling well, they're post-transplant, they had a lot of medical care, and now they still have to come in relatively frequently, but they feel great. So I think that's definitely a contributor. And then once they develop symptoms, they're more likely to come in. Also, then depends on uh, their proximity to clinics that can do the PFTs, and then who can interpret these PFTs. A lot of the PFTs, yeah, can be complicated by other issues of restrictive conditions and whatnot that make it difficult to diagnose. And so um, that's my understanding of why it can be difficult. Yeah. Mhm. Cool. Well, it's 1 o'clock, so thank you all for coming. Thanks for everyone who's on Zoom. Really appreciate you guys covered.